Hello, everybody. My name is Ryan Atkinson, and welcome to today's webinar, COVID-19 Prevention for Immunocompromised Individuals. Ask the Experts. Our activity today is provided by Prime Education through educational grant support from AstraZeneca Pharmaceuticals. Now, today I am very excited to be joined by our expert faculty presenting today's webinar. Please join me in welcoming Dr. Shamel Shoham as well as Dr. Michael Anderson. Just a second, I'm going to ask each of them to introduce themselves and then quickly turn the program back over to me for just a few housekeeping items so that you can get the most out of today's webinar. Dr. Shoham, would you like to start us off?
Sure. Hi, Shmuel Shoham. I'm an infectious disease physician at Johns Hopkins and professor of clinical medicine there. My focus is on patients that have transplantation or cancer and work to prevent and diagnose and treat infections in those patients.
Hi, I'm Mike Anderson. I'm a pediatric critical care physician. I have a number of different hats that I wear. I'm here at Children's National Medical Center, where I'm on the medical staff at GW as well. My full-time job, however, is I'm a senior advisor at the Administration for Strategic Preparedness and Response, and for 2+ years have been on what used to be known as Operation Warp Speed, now called the Federal COVID Response, primarily dealing with therapeutics. It's really an honor to be with you, and as you see the little disclaimer down there, these are my professional opinions and not necessarily that of the federal government.
Outstanding. Again, thank you both for being here. And Dr. Anderson, while you do wear lots of hats, you don't have one on today, it looks like. But
I can find one.
I'm just kidding. Wonderful.
The Children's Hospital, we got hats. We've broken this into several really important chunks. First is who are the patients that we're talking about today? Who are the patients that are at risk for progressing? And we'll just acknowledge from the beginning, I can't believe we're 3 years into this. We're worried about the winter. There's still shifting variants out there. There's shifting therapies that remain available for clinicians to take care of patients. But every patient deserves our best and deserves us to make sure that we're at the top of the game. So I really appreciate everybody being here. And I'm just going to kick it off very quickly about talking what are the patients that we're most concerned with? What underlying medical conditions make patients more predisposed to bad outcomes from COVID-19? Once again, 3 years into this, we're getting pretty good at identifying those patients. And you can see those on the left-hand side shaded in blue. Those are the patients we know that at least one systematic review, one meta-analysis has shown these are the patients that we are concerned if they do turn positive for COVID-19 can have pretty significantly bad outcomes. And of course, age, diabetes, heart disease, obesity, a BMI greater than 30, solid organ transplantation. My learned colleague will talk much more about those particular high-risk immunocompromised patients. The slider left or a slider to the right, light blue, those sort of middle-of-the-road patients we're not exactly convinced they are the most at risk, but certainly deserve a conversation with their care providers of what options do they have if they do get COVID-19, and then some mixed evidence you can see to the right. So obviously this 3 years of horrible experience has really helped us refine what are those patients with comorbidities that we are most concerned with that could evolve into really bad outcomes from COVID. And we're going to talk in a little bit more detail about those patients with immunocompromising conditions or those on immunocompromising medications, and what, if anything, do we do in a pre-exposure prophylaxis methodology or therapy, I should say. Moderate to severe immunocompromised, once again, I think about this maybe artificially, patients with immunocompromised conditions or patients on immunocompromising medications, or obviously a lot of patients have both of those. And you can see those listed here. These are patients, once again, greater than 18. I'm a pediatric intensivist, but this is mostly in adult patients. Those following conditions that make them, quote unquote, moderately to severe immunocompromised. And I did not know this before helping prepare this. And obviously, Dr. Shoham did. 12% of adults are immunocompromised across this country, despite making 12% of COVID hospitalizations are in patients with immunocompromising conditions, despite being less than 3% of the population, and have a much higher risk of winding up in ICU or having really bad outcomes. So once again, people are sick of COVID, they're tired of COVID, but we as clinicians, we as public health advocates need to make sure that each and every patient gets these therapies if appropriate. So I'll tee up our first question, and then Ryan can help me with the rest of it. As you look at your biggest challenges to supporting COVID-19 prevention for the immunocompromised individuals, those patients that I sort of superficially went over, that we'll talk about in much more detail, is you see A through F here. Which are the biggest challenges that you're seeing in your clinical practice in supporting these patients and preventing immunocompromised patients from getting COVID? And I think that sort of we will go back and forth a little bit as you are. I believe the poll should now be open.
So you should have a text box that popped open on your screen with each one of the options A through F available for you to select. There is a radio button located next to each one of those options for you. Once you select that radio button, go ahead and hit the blue submit button. That will share your answer with everybody that is on the call as of right now. And I will let you know, gentlemen, that as we are trending, the top answer, or right now, A, identifying patients who may not mount adequate immune responses, is our top response, followed very, very closely by identifying patients who would benefit from pre-exposure prophylaxis are the top two leading answers. And I'm curious, from your point of view, what are you seeing within your practices? What are you hearing within your patient populations or your colleagues?
Dr. Shoham, take this one away. This is going to be the bulk of your presentation.
So the biggest challenge in my mind is E, counseling patients about COVID-19 prevention. And the reason that that's the biggest challenge is that it is a changing field. There was previously there were maybe 4 pillars of preventing bad outcomes from COVID, and those were vaccination, pre-exposure prophylaxis, creating a safe environment for the person who is immune compromised, and then the fourth was identifying people that have an infection and then quickly treating them appropriately. We have lost one aspect of that of the pillars, and that's pre-exposure prophylaxis for now. And I'll go about I'll talk about that soon. And then we've also lost one treatment modality in terms of the monoclonal antibody. So we still have 3 pillars, and you can have a building being stable on 3 pillars, but it's not the 4 pillars that we had. So with that, let me move to my presentation, talking about some prevention strategies for immunocompromised patients. So I started with the good news is that we have a lot to offer in 2022, and the bad news is that we have less to offer now at the end of 2022 than we had at the beginning of 2022. So we'll start with the most important treatment or therapeutic modality that we have for prevention, and that's vaccination. There are 4 different platforms of vaccines out there. The mRNA-based platform, and that's there's 3 vaccine products out there. BNT162b2, which is the Pfizer vaccine. mRNA 1273, which is the Moderna vaccine, and then the bivalent booster vaccines, which Pfizer and Moderna both have versions of those. Those are all mRNA-based vaccines. Then there's 2 other platforms. One is the NVX-CoV 2373, which is the Novavax vaccine. And what that is it's got 2 components to it. It's got a protein subunit, which essentially is the spike protein. And then it has something that is derived from the soap bark tree in Chile, which is an adjuvant. That is something that activates the immune system, so that when the immune system sees that plus the spike protein, then it's activated to form B and T cells directed against the spike protein. Going back to the mRNA, the way that the mRNA vaccine works is that it is a sequence of the spike protein, and then it's injected. It's taken up by cells near the injection site, and then those cells turn the mRNA into protein, and then that protein is the subunit protein, and the body reacts to that. So that's the mRNA platform, the Novavax, the protein subunit platform, and then the third one is the adenovirus platform, which is in this country, it's Janssen. In overseas, there was another company that was making an adenovirus vaccine, and the way that works is there is a sequence of the RNA or the sequence for the spike protein that's in an adenovirus vector. That adenovirus is injected as a vaccine. It goes into cells. It infects the cells, but infects it in a way that's not harmful to the recipient, and then it starts pumping out protein again, spike protein, so that the body responds to that. The mRNA vaccine is approved from Pfizer, is approved for people 12 years or older, and authorized for infants 6 months or older. And that's pretty new, that authorization. And the Moderna vaccine is FDA approved for people 18 or older, and for authorized for children 6 months or older. And the Novavax is authorized for 12 years or older. The adenovirus vaccines, the one that's Janssen or Johnson & Johnson, that's authorized for 18 years or older. However, that vaccine has sort of fallen out of disfavor generally because it has a signal for toxicity in terms of hematological toxicities, clotting and bleeding issues. So it's sort of fallen out of favor. The bivalent booster vaccines, the way that those work are that they're, again, mRNA vaccines, and they have a combination. The one valent is if you will, COVID classic, the original COVID, and then the second valent is for Omicron. And the reason that you have the combination is it was felt that the original one would provide broad spectrum COVID coverage, whereas the Omicron valent would provide additional activity against the virus as it's mutated over time. So that's the vaccines that are out there. And I'll walk you through this slide in terms of the vaccine dosing. So pretty much if you have an immune-compromised patient, I can't imagine that they would not have already gotten their primary dose 1, probably dose 2, and probably dose 3. And then what you're trying to get them now is should you give them the bivalent booster? And for me, the answer is a resounding yes. And the rationale for that is that over time, the vaccine efficacy may wane. So a booster is a good idea. And more importantly, a booster that is more directed toward the kind of circulating variants that we have out there, which is the bivalent. So when should you get the booster? 2 or more months after you've had your last vaccine. Are people that should be getting the boosters getting the boosters? Yes and no. I think that uptake, there's a lot of COVID fatigue out there, and uptake in terms of the booster has not been as robust as one would like. And I think it's an area of ongoing work to try to close that gap. Why is that gap so important to close? Because this is the main thing that we can do in terms of building up people's immunity so that they either get a milder version of COVID or don't get it in the first place. If one is pursuing the protein subunit vaccines, then it's a couple of doses and then a booster dose. And since there is no booster, bivalent booster for anything except the mRNA booster, then that's the direction that one should go. So that's your vaccine sequences and schedules. And let's talk about 47-year-old patient, history of liver transplant, 2018. He received primary COVID vaccine and several booster doses. In fact, he's actually had more than several because he's been part of a study. But in general, this would be a patient that we would see, somebody who's had multiple boosters. He is concerned about developing COVID and associated complications, particularly now as the world is opening up and people are expected to be at their job physically more and more, and people are now going to be going to holiday parties and being in isolation for 3 years is a long time. So is there something that he can do to protect himself against COVID?
And this answer changed a couple weeks ago for you, correct?
That is correct. And actually, let me go back. So one of the things that was a slam dunk for me in the past was to give him pre-exposure prophylaxis. And the reason for that, I'll go in the next few slides about what I would expect in terms of his response to a vaccine. But pre-exposure prophylaxis with a long-acting monoclonal antibody would give him antibodies that would be circulating so that if he came in contact with the virus, it would bind to the virus and neutralize it. Unfortunately, and you've probably heard this, is that the virus is constantly mutating and there is variants that form. And what those variants can be are variations at the place where those antibodies bind. And that has happened with all of the monoclonals that are out there now, including one that's used for post-exposure prophylaxis, so that only a minority of the circulating viruses in the U.S. right now have a surface that the pre-exposure prophylaxis monoclonal antibodies can bind to. So I'm no longer recommending that approach. But there are things that I can recommend to him, and I'll get into those in a couple of minutes. But first, yes, I'm going to recommend that he be vaccinated as he has been, but I'm also going to tell him that all is not perfect with vaccination. So on the one side, you can see a meta-analysis of 81 clinical trials. That's a lot of work looking at immune responses to vaccines in immunocompromised patients, but 81 trials. And of those, they found that if you got one dose, about a quarter of the people had seroconversion. That means they developed antibodies that are protective. A quarter of the people. So nobody should get one dose. One dose is better than 0 doses, but nobody should get one dose. 2 doses, it goes up to 57.1% seroconversion. And 3 doses, it's 48.65. So you think, oh, wow, that number is lower. How is it possible that I went from 2 doses and I had 57% response and I went to 3 doses, 48? That's responses in people that didn't respond in the first place. So that's on top of the 57%. I'd love it if it's at 3 dose 100%, but that's not the reality. The reality is that many immune-compromised people will not respond no matter how many times you vaccinate them. And the reason for that is that that part of their immune system, which is activated by the vaccines, is suppressed. It's either suppressed because of a medication that we give them. For example, Cellcept or mycophenolate is a big problem. And if patients are on that, then they have a less of a response to the vaccine. Rituximab is a huge problem. Patients that have received that have very poor general responses to vaccines. And people that have hematological malignancies, also huge problem. And hematological malignancy, particularly lymphoid malignancies like CLL and other lymphoid malignancies, can really impair the person's ability to develop good immune response to the vaccine and can put them at risk for more complications. And putting that sort of pictorially, using a meta-analysis of 82 studies, you can see that HIV patients, the relative risk for seroconversion is 1. That means that they will seroconvert, and the comparator is people that are not immunocompromised. So generally people with HIV, of course, there's going to be exceptions, but generally people with HIV will seroconvert as often as people who are not immune compromised. Solid tumor cancers, those people tend to be less immune compromised than some of the other ones in the list. They will respond pretty well as well, but maybe not as well as the HIV and the non-immune compromised. Immune disease, that's people generally with rheumatological conditions or other autoimmune diseases. So now they're getting a little bit more immune compromised to control those. Heme malignancies for the reason that I talked about, and then solid organ transplant have the worst response to vaccination. That doesn't mean zero response, and this is by seroconversion. That means we're only measuring antibodies, so it doesn't speak to other parts of their immune systems. For example, T cells, they may be functional, but the conversion rate is not as good. Moving on to then the development of severe COVID after primary vaccination series. So this study was done before the booster, so people that were primary vaccinated. And you can see that there's risk factors for doing poorly, getting sicker. And those are listed in the 8 identified risk factors for COVID-19 outcomes after primary vaccination series. And one of them is immunosuppression. But you know from taking care of patients that patients don't need to just have one condition. In fact, in immunocompromised patients may often be older than 65, have diabetes, chronic kidney disease, and immunocompromised, or cardiac disease, or chronic pulmonary disease. It's combinations of all those. And then you can see from the graph, as you start picking up more of these additional risk factors, the risk for having bad outcomes increases, so that and you've probably seen this in your practice, it's pretty rare in December 2022 to see somebody in the ICU with COVID who doesn't have a whole bunch of these conditions simultaneously, and now they're in the unit. Part of the reason that they're in the unit is because their underlying disease might have been tipped over by the COVID, and part of the reason they're in the unit is because their COVID is bad enough because they have little marginal reserve. And it's often hard to know, are you in the ICU because of COVID or with COVID? And if you're the patient, it doesn't really matter. You're in the ICU. So that's a thing to consider. Monoclonal antibodies for COVID-19 pre-exposure prophylaxis. So a little bit of history of monoclonal antibodies and neutralizing monoclonal antibodies. They were developed in record time from the time that people had the diagnosis in their hands that this COVID thing is happening, to the time when REGEN-COV became available, and soon thereafter came, and that was casirivimab, imdevimab. Soon thereafter came bamlanivimab and its various combinations, sotrovimab, and then most recently bebtelovimab. But as you can see by the graph, they all have become difficult to use long term because resistance develops. And the resistance develops in the forms of mutation of the spike protein, so that they no longer work. Concept works. It's possible that some of them may be recirculated and work in the future, but right now there are no monoclonal antibodies effective against treatment for COVID or for prevention. And this monoclonal antibody combination, tixagevimab and cilgagevimab, which we had used in so many patients to provide them that fourth pillar of protection, just can't use it anymore in our area and in many parts of the U.S. Because of high levels of resistance. When were we going to use it? Not as a substitute for vaccination, but in people that either couldn't get vaccinated for whatever reason, or people that had been vaccinated, but as I mentioned in the earlier slides, weren't expected to have a good response. What did we learn from all this? We learned that you can deploy pre-exposure prophylaxis. We learned that it was effective in preventing infection. We also learned that these monoclonal antibodies have a shelf life in terms of efficacy. So what should we do with pre-exposure prophylaxis? I think we could do two things. One is we can stick them in the fridge so that if new variants come out that are sensitive to those, and that has happened, is that sometimes there's been sort of recycling and a new variant came up that was susceptible to something that before had not been, then we have them to use, and we can do some introspection about what we learned about delivering pre-exposure prophylaxis to immunocompromised patients. I have seen this, and I'm sure you've seen this as well. Patients that get sick with COVID, you look at them and they're like, wow, this person never got pre-exposure prophylaxis. Why did that happen? You more often than not see that there was a failure in the communication system between the public health officials, the doctors, and the patients, that this could be beneficial. Was this going to make...
I'm sorry to interrupt. We could probably bounce around during the questions. As I understand the numbers, there's about 300,000 Americans across the country that did get shelled at some point, and now that the variants seem to be less impacted by this monoclonal cocktail, maybe during Q&A you can, and it's currently still EUA authorized, but I think you very eloquently said, but in your area, if variants are emerging that are not sensitive to this drug, then why use it? So there's some interesting choices, I think, for clinicians out there.
Yeah. And so then you can also ask, okay, so say it got you 10% protection, would you still go for that? And I would say probably not. And the reason I would not is because when you're doing one thing, you're not doing another thing, so you're taking up resources to do something that isn't going to be particularly effective. And as my wife says, if you're putting something in your body, it can have a side effect. It doesn't necessarily. This drug is pretty safe, very safe. There have been some signals, including in an article recently published in Lancet Respiratory Medicine, that some signals of cardiac complications. Hard to know exactly what to make of those signals, but it's not like you get a free go at it. When you inject something, it can cause toxicity, and I would say that the number needed to treat to prevent one infection is going to be astronomical now. And then the other part of it is you may be giving people a false sense of security. I recently had a patient in the clinic who had respiratory symptoms, and I asked them, did you check for COVID? And they said, no, I'm protected. I got the monoclonal antibody. And I said, well, actually, you're not. And we checked them, and they ended up having rhinovirus. So definitely Evusheld will not protect you against rhinovirus. Let's go to the next slide about what. So this is the data that basically shows the teal here was where the light green was the main variant that was against which the drug was effective, and you can see over time it's reduced to a very small minority, and so neutralizes BA4, BA5, and then this rare BA 2.21, but not all the ones with the Qs in it and the BA6, and those have sort of taken over time. The other thing that we now need to consider, even more so than we did, although we never should have stopped considering it, is what can people do in terms of non-pharmacological approaches. So the number one non-pharmacological approach that I recommend is vaccination of all the people around the person. Some people talk about it as a cloud vaccination approach, also known as cocooning. But if you can get all the people around the person vaccinated, whether that's the people at their workplace, the people at their home, the people that they play bowling with, then there's just fewer chances for them to come in contact with somebody with high viral load, and therefore somebody that can transmit. In addition to that, a lot of ink has been spilled about masks. They are effective. They're most effective when a lot of people wear them. An individual sitting in a waiting room who's the only one wearing the mask is still going to be better off than not wearing the mask. But it unfortunately has also become a political issue. But from an infectious disease perspective, I think that masks do two things. One is for the person who has an infection, they may not know they have an infection. It serves as a source control so that they don't cough the virus around as much. And for the immunocompromised person, they can provide some sort of protection against inhaling the virus. I think it's beyond the scope of this talk as to what is the best mask, but in my opinion, the best mask is the one that somebody will wear. Notwithstanding a certain article that recently came out from China showing, or it wasn't even an article, I think it was something in the press showing that one jogger in a pond passed COVID to like a zillion people around them. I still think that a well-ventilated area and being outside is far better than being in a closed space in terms of protection. So how you put all that into a decision as to whether somebody can go to a Christmas party is a very personal issue that is best discussed between the patient, their family, and a trusted healthcare provider. And with that, I think I go on back to you. Is this still me? This might still, yes, it is still me.
Sir.
All right. So the one of the pillars is quickly identifying when somebody is infected and treating them, because we know that in the viral phase of the infection, when the virus is running rampant before the immune system has had a chance to kick in and to sometimes go into overdrive and cause the damage, that killing the virus is a good thing. And we have 4 antivirals out there in the world that are effective. There's some other ones that you may read about on Facebook, but the true ones that are effective are remdesivir, nirmatrelvir ritonavir, which is called Paxlovid, molnupiravir, and high titer convalescent plasma. So when are those going to be effective? Overwhelmingly, they're going to be effective early on in the disease. However, there are some immune-compromised patients that have smoldering or ongoing infection with high viral loads that would still be it would still get benefit even after the few days that are best for non-immune compromised people. And the reason for that is because the immune compromised people will tend to have a higher viral load for a longer period of time, and therefore an antiviral will be effective. Remdesivir needs to be given by IV, so it can be difficult to do in the outpatient, not impossible. Paxlovid given by oral. However, it does have that ritonavir component, which is a big problem in terms of drug interactions with people getting drugs like cyclosporin, tacrolimus, sirolimus, everolimus. They can cause those levels to spike up. I recently saw a patient that had a tacrolimus level exceeding 180, which is typically a level of 10 is a good level for most people, or even lower than that. So it was about 20 times what was expected, and with a lot of toxicity from that, and that's because of that drug interaction. Molnupiravir. So if you can use it, that's great. But if you can't because of drug interaction, then that's a problem. Also, people on Paxlovid have a horrible taste in their mouth, and that taste can last for a long time. There's different things one can do. Cranberry juice. Back in the early days of HIV, when we were using ritonavir as an HIV drug, we gave Nutella. So there's different things that can be done. Molnupiravir is not as effective as Paxlovid. And there was a recent study that came out from the UK, an open label study, where they showed that it wasn't as effective. It was as effective as standard of care. And from that, many people said, see, it doesn't work because it's as effective as standard of care. What people didn't realize is that the immune-compromised patients, which are the ones that I focus on, the standard of care for them actually often included treatment. So I would say that the flip side is molnupiravir is in that population of people, it was not as good, but not statistically significantly not as good. So what I would take from that is that molnupiravir is an option, not my first option, but it's not a completely useless option for immunocompromised people. And so that's molnupiravir. And then high titer convalescent plasma is an area near and dear to my heart. Same mechanism as the monoclonal antibodies in that it's a neutralizing antibody, and advantage is that it still is effective if you get high titer product, which is what is available now, and collected. The more recent, the better, but even stuff that was collected before Omicron is still somewhat effective. The disadvantages of high titer convalescent plasma are that it is a blood product, so there's certain issues around logistics of a blood product. And then I would say that the other problem is that it wasn't developed by a pharmaceutical company, so that's an advantage in that there's a lot of different places that develop it, but the disadvantage is that the marketing for it hasn't been as organized as one would expect with a drug company product. So, but it's there, and it's one of the 4 that are active. And with that, I'll turn it over to you.
Thank you, sir. I just want to go back to this slide for 1 second as the pediatrician or pediatric intensivist on the call to say kids are, in my estimation, my professional opinion, still a little underestimated or underrepresented in the available therapies if you have a high-risk kid. Remdesivir is fully FDA approved for younger kids all the way down, I think, to age 6 months. Paxlovid down to age 12. Lagevrio, age 18. And I think convalescent plasma is adults only, but I have to double-click on that. So we've still got high-risk kids. RSV and flu seem to be more of a problem, obviously in children, with the children's hospitals being flooded right now, but I still think we have work to do. And remdesivir, quite frankly, in some very innovative children's hospitals is really a mainstay of therapy. As my learned colleague points out, it is an IV dose once a day for 3 days, so the logistics around that are not small. So in our presentation, we've tried to tee up who are the high-risk patients that we're worried about, a really terrific discussion on how do we prevent patients from getting COVID, a really interesting, ever-changing landscape on what therapies we can bring to bear if patients do, God forbid, turn positive, and just a little bit about promoting awareness and sort of increasing health equity awareness around these therapies. Once again, 3 years. I can't believe we're 3 years into this battle, but we're still battling some age-old discrepancies, and that is racial and ethnic disparities in who gets monoclonals. This is from several months ago. However, patients in African-American communities, patients in underserved communities, back when we had this robust sort of library of available therapies, we're not getting therapies as often as patients from more affluent neighborhoods or white race folks. Socioeconomic status, household composition, disability, you can see what's called an SVI, or a social vulnerability index. This once again is from the middle of 2021. A little bit of follow-up data shows we're doing slightly better, but unfortunately we still see socioeconomic disparities. So going into what could be a very long winter, and a challenge of having less available therapies than we did before, I think really double clicks on, and it was a slide a couple slides ago, our patients need a plan. If you're at risk of getting really bad outcomes from COVID, does that primary care provider, that nurse practitioner, that family medicine doc make a plan with that patient? If you turn positive, there's a very finite period of time. 5 days of symptomatology is what the EUA authorizes the 2 oral antivirals. How do we quickly get this therapy to you? How do we make sure that you understand you've got to get this therapy within 5 days of symptoms very, very quickly? So how can we educate patients? First and foremost, talk about vaccines. And there's a lot of good questions in the chat about vaccines. Unfortunately, there is a ever slowly growing line across pre-exposure prophylaxis. It looks like our one EUA authorized will probably be taken off the market by the FDA really soon. Really having a discussion with the family and with the patient about the emerging variants and about what other options patients have. And then, of course, talk about the EUA. I just like that notion of make a plan with the patient. If you do turn positive for COVID, This isn't over. We want to prevent you from getting sick and having bad outcomes. Of course, we want to prevent our health systems from being overwhelmed as we go into the winter of 2022. So this notion of having a plan and making sure as many patients as possible can benefit from therapies is really important. And we all play a role, whether you're a community advocate, a patient advocate, a nurse practitioner, a pharmacist, a physician. You can just sort of see here what are the different ways that we can step up to the plate. Once again, people are COVID fatigued. They're tired. There's a lot of other things going on in healthcare, including burnout, a lack of workforce, and overwhelmed ERs. But as you can see here, from case management members to physicians, let's make sure that we all understand our patients need a plan, and we need to bring every available tool to take care of them. So educating patients is really, really important. The federal government also has assets and resources. President Biden announced way back at the State of the Union this whole notion of test to treat. How can we take more availability of rapid testing and combine that with the use of telehealth and other sort of notions to make sure as quickly as somebody tests positive that they're offered these important life-saving therapies. Once again, that 5-day window for the EUA authorization of orals goes by very, very quickly. We'll make these slides available as a clickable link. We can see here ASPR, the administration that I work for, the agency I work for, healthdata.gov and vaccines.gov all have interactive maps with clickable links that can take you to a place. This is my zip code. This is where you can find a rapid test to treat center across this country. So that's our presentation, and I believe we'll turn it over now to Ryan to walk us through the next steps.
You got it. No, very good. Great information. So we did have several questions that come in, and I do apologize if we can't get to all of them. We'll do our best to navigate and try and group some of these questions together. So, gentlemen, I know we did talk about resources just on the previous slide, but there was a couple of questions that came through that, from your perspective, is there a resource or is there a guide out there that we can utilize or will help us to understand the various primary immunodeficiency conditions and the respective risks associated with COVID? Can we provide any guidance there? Do you know of anything or something that you utilize right now?
It's very difficult because even in amongst patients, there's so much diversity. So it's really quite individualized. You look at a solid organ transplant recipient, and one person may be a lung transplant recipient, so they're going to have a higher risk of having respiratory tract infections, and they're on multiple drugs to control their repeated episodes of rejection. That's going to be quite different than, say, a liver transplant recipient who's on very little immunosuppression 5 years out. So I think it's still taking into consideration the net state of immunosuppression, and the basic principles are that if the B cells aren't working, that's a real problem for an infection. If there's pre-existing respiratory abnormalities, that's a real problem, and then everything else sort of builds from that. With again the highest risk being hematological malignancy patients and solid organ transplant recipients that have multiple comorbidities, and then the lowest risk are in terms of immunocompromised people are people with solid tumors. Even if they're getting chemotherapy, still lower on the risk of having major bad outcomes. One thing that I wanted to talk about in terms of a treatment approach is minimizing the immune suppression to the extent feasible. And the big bad drug is mycophenolate. That really gets in the way of the body's ability to have the lymphocytes do what they need to do to fight viral infections. So if somebody has COVID and they're calling their transplant team, one of the questions they should ask, or if you're the transplant team, one of the things you should ask yourself is, what can I do about the mycophenolate? Can I stop it or reduce it, or what can I do about it?
I think under resources, Ryan, I would list two that just over my time at the federal government, I think the NIH treatment guidelines have really tried to keep up with this incredible variable changing what variants in, what drugs out. And then I also think the IDSA has really tried to keep up with emerging. I mean, it's ever changing, but I think between NIH clinical guidelines and IDSA, those are two other good sources.
Excellent. Wonderful. Thank you so much. Another question that came up early on in the presentation was, do patients that have hematologic malignancy, are they considered high-risk patients?
I think there was a list that went through there, and it's possible that it didn't highlight those type of patients specifically, but I would say that hematological malignancies, and in particular, people with lymphocyte depletion or lymphocyte deficiency, that either they don't work or there's not enough of them, that's a huge risk for bad outcomes with COVID.
And we'll triple check the slides if that wasn't on there. That's an error.
Got it. No problem at all. No problem at all. Another question that came in. So should immune suppressed individuals have more than one bivalent vaccine? If so, how soon after the first bivalent vaccine?
I don't know. I think that the story is still written about whether additional vaccinations beyond the one bivalent will be needed. My guess is that at some point in the future we'll be, in an immunocompromised patient population, we'll be going toward periodic revaccination, either with existing vaccines or with new strains, but that's just a guess.
No, got it. Very good. Okay. And I know we touched on this a little bit, but can we reiterate this? So speaking to the bivalent vaccinations, as Omicron is now being replaced by the BQ variants that appear to be availing the Omicron immunity, and this is as the question was being understood by the person asking it. Can you speak to the effectiveness then of bivalent with the new variants that are coming out or that we're seeing within the industry?
I think my colleague is trying to answer, but he's
muted.
No, he is looking for your learned answer, sir.
Looking for my learned answer. So I think that the story is to be written about how the bivalent vaccine, which was developed against against some of the earlier Omicron subvariants, is going to be effective against the later Omicron subvariants, I think it's still to be determined. I think some of the data that's been described in the literature, just looking at in vitro work, it raises questions as to exactly how effective it will be. But I think it's going to be a little bit of time until we know really how effective it is in the field, as opposed to whether the antibodies produced in people that have received it are able to neutralize the virus in the test tube.
No, very good.
One thing that we've seen in our work on convalescent plasma is that people that have had vaccination of any kind and have had the infection, which increasingly more and more people, including immunocompromised people, fall into that category, have astronomically high rates of antibodies that continue to neutralize the virus. So what that tells us is that you can't look at it in a vacuum. That people bring in multiple other immune experiences to the table, and many of the people that have received the current bivalent vaccine may have also have had an infection, and then they're probably well protected with their antibodies. But again, much more work to be shown. One of the things that came up earlier, this is not a talk about convalescent plasma, but it can be used in kids, providing that the pediatrician and the parents and the kid all are on the same wavelength.
Thank you for that. I should know that. Hey, can I just double click on the question that we started with? And I'm sorry, Ryan, just to go to
Please,
this.
no, go. All you.
The 300,000 Americans that did get the pre-exposure prophylaxis, and upwards 3 months ago, 2 months ago, it was deemed effective. And now I think you've made the appropriate decision based on your emerging variants. But are you aware of agencies sort of actively calling folks up and go, by the way, this is not as efficacious now with the emerging variant? Is there any active outreach going on that you're aware of?
So in our system, we let people know that that it's not as effective as it was against the new variants, and also when people come up for renewal, because it lasts 6 months, or when there's newly immunocompromised people that have just had a transplant or just have gotten chemotherapy, then we're not offering it to them.
Got it.
Oh, very good. So I know we talked about the mycophenolate, but we also had some questions specifically coming in around rituximab as well as IVIG. So do those have any effect on patients in this space, taking the vaccinations and treatments for COVID? If so, is it treatment that is currently undergoing, or this particular question said if someone took, for example, rituximab back in 2017, is that something that's still going to be impacting their current treatment, or has enough time passed that it's no longer something to consider?
Sure. So I'll take the IVIG question first, in that IVIG is not expected to impair one's ability to fight COVID. In fact, if anything, it might help with two different mechanisms. One is that IVIG is collected from a population of people that donate their blood, and more people have either been vaccinated or had infection. I'd say probably you'd be hard pressed to find a single individual in the U.S. who was not vaccinated and didn't have infection. So that antibody has now filtered into the IVIG stocks. Whether that antibody is protective enough because it was probably collected more than 6 months ago, or whether there's a high enough concentration, that's less clear. But they are probably protected to a certain degree from getting IVIG. The other thing is that IVIG can reduce the chance of bacterial superinfections. So, for example, pneumococcus or other bacterial infections, when the antibodies from the IVIG are there. And so it's sort of like COVID can be a double whammy. First you get the infection, then you get a bacterial superinfection. So they're sort of protected there. That's the IVIG part. Rituximab is typically, we tend to think that it's about 6 months is how long it lasts in the system in terms of doing its damage. It can go up to 12 months. I'd say if somebody got it in 2017, it's extremely unlikely that it's having an ongoing impact on them.
Very good. So we mentioned before, and there's a couple questions that came in about this. So the cloud protection effect, so vaccinating those surrounding certain individuals. I know you probably couldn't give us a percentage, but in your experience, is that effective? And how effective has that been in regarding the prevention of the transmission for those patients?
There's very little that's been published on this cocooning or clouding in terms of data. There is some data that I don't have at my fingertips about this being efficacious in terms of a prevention against the person coming into contact with COVID, and we actually do the reverse of that in influenza. We vaccinate a ton of kids for influenza, both to protect the kids, but also to protect grandma and grandpa from getting influenza from the kids. So I don't know, maybe my pediatrician colleague can talk about why we vaccinate kids for influenza and its downstream effect on people around them.
Just what you said, and I would add, my full-time job is actually helping deal with the pediatric surge right now, and the fact that we can hopefully prevent grandma and grandpa from getting very sick. But right now, the children's hospitals are just on vapor thin sort of capacity right now. So it's a true public health emergency to get as many kids vaccinated. I like this notion of a cloud, but the cloud is also trying to protect the infrastructure of American healthcare right now, going into a really challenging winter.
Mm-hmm.
So here's a good question, and maybe we can't answer it on the national level. So the question is what's being done on a national level to improve vaccination rates as well as to quell vaccine hesitancy with the misinformation out there? So maybe we can't speak to the national level, but maybe what you're seeing done at your level or local levels to help tackle some of those questions that are coming up or hesitancies that we're seeing?
I'll speak about pediatrics quickly, and then hear more from my adult colleague. I think pediatricians have been, proponents of vaccination and trying to fight misinformation for a very long time. The last 3 years, I think, has been the greatest challenge in pediatrics, and once again, now in the middle of so many kids getting sick with so much. Every office visit, every ER visit, every urgent care visit is that just in the trenches talk between a pediatrician, a family medicine doc, a nurse practitioner, and that family about the importance of vaccines. However, misinformation, disinformation, conspiracy theories, whatever it is, it's unfortunately making that fight harder and harder. And I think it's going to take a long time to recover from.
So one of the questions that we struggle with all the time is how did we get to this situation of vaccine hesitancy? And I think a part of it, there's been a concerted efforts in some groups to I think in an attempt to hit back at perceived elites, to go after scientists and vaccination as sort of an arm of that. And I think that how do we fight against that? Individually, trust is gained in drops and lost in buckets. So working with the people that we work directly with to gain their trust, and I think that's the. I think to me that's the secret sauce is gaining trust, which doesn't happen in a day, and gaining it back.
Well, very good. I appreciate that. Thank you so much. I have gotten a couple different questions now, specifically about the risk associated with COVID-19 and the new complement inhibitors. Do we have any insight into that, or any data that's available yet?
So the most interesting aspect of complement inhibition is that it may actually help COVID. And so again, looking at COVID and having first the viral phase and then the immune, hyperimmune or immune overactive phase, and then the risk for bacterial and fungal superinfections. Complement inhibition is not going to help as an antiviral. Complement inhibition is not going to help against bacterial or fungal superinfections. But one of the things that happens when the immune system goes into overdrive is it activates complement. So complement inhibition has been looked at as a therapeutic for COVID, and there's been some interesting findings. Not quite ready for authorization of a complement inhibiting molecule for treatment, but in people that are in that hyperinflammatory condition, which we're seeing less and less of. I think that the interaction of the virus with the immune system is less inflammatory than it had been for a variety of reasons, maybe related to the virus, maybe related to more immunity in the general population. But when you do see that inflammatory condition that we treat with steroids or with IL-6 inhibitors or maybe with IL-1 inhibitors, complement inhibition may join that group as an option.